As a type 1 diabetic, want to know what absolutely terrifies me? Hospital doctor.
When I was in training, if there was ever a person with diabetes who came in with like a DKA rule out kind of scenario, and if they were cognizant enough to have a conversation, I think there was about a 50% chance that they were like, hey, this feels suspiciously like the time I went to the ICU and was on an insulin drip. It was very, very sick, and I was breathing this kind of way. Like, they kind of give you the answer, and I think sometimes you get in your own way trying to be fancy with sick diabetes management, because there's the sub-Q directed protocol, like the SQUID protocol, and there's like the high dose insulin drip versus the zero point 0.1 units per kg per hour. Like there's all these different protocols that I'm sure hospital administrators and different people like to nerd out about. But at the end of the day, even in mild DKA, usually the patient comes in and is like, hey, this feels like DKA. And even if you don't want to give the patient the benefit of the doubt that they know their own body, which is probably a problem, legally, medical legally speaking, if you have somewhere in your chart, in a nursing note or in a tech note or in a triage note that says, hey, this feels like last time I was in DKA, if you don't initiate treatment to that level of severity, it's probably going to be hard to defend that case. And it doesn't mean everyone needs insulin drips. It doesn't mean everyone even needs to go to a step down, let alone an ICU. But it means when you initiate treatment, you have that initial encounter with your patient. If your intention is, I'm taking this concern seriously, I'm getting the labs, are you getting a gas? Are you getting a beta hydroxybutyrate, whatever your shop has? Are you looking for a source of infection? Because DKA sometimes is not primarily from diabetes management or mismanagement. It could be from stress or infection, medication side effect, for all sorts of different reasons. If you start at that level of sincerity and then work your way down as you are given evidence that you don't need that level of care, that is much easier than starting at, I think they're fine, and then having to double back and increase afterwards. That's hard to gain rapport and to establish rapport with patient that way. And it's hard to get that momentum back on a severely acidotic patient.